Well, welcome back, everybody, and officially good afternoon. We now convene for our next session, the importance of inclusivity in cancer care with Dr. Stella. Stella is a researcher and educator whose work advances equity-driven, trauma and violence-informed approaches in cancer care. She's completing a postdoctoral fellowship with the Improving Cancer Care Equity Lab at Women's College Hospital under the supervision of Dr. Ambreen Sayani, supporting initiatives that strengthen equitable cancer care delivery across health systems. Stella's scholarship translates trauma and violence-informed care principles into practical tools and strategies that foster emotional, cultural, and physical safety, honor choice and collaboration, and build on the existing strengths of people living with cancer. Her work draws on patient-partnered research and implementation science, including co-designed lung cancer education module that centers TVIC in primary care and supportive care contexts. Stella is committed to actionable, equity-driven care approaches that ensure people affected by cancer feel safe, heard, and supported in ways that respect identity, lived experience, and structural barriers to health. This is one of the most critical topics in terms of improving our outreach awareness and getting to under-supported populations. So Stella, thank you so much for being here with us today, and I'm thrilled to pass it over to you.
Thank you so much for a lovely introduction, Christopher. It's an absolute honor and a pleasure to be here with all of you. And now I will share my screen with the presentation. So just give me 1 second. And if things don't work, please let me know. Okay, it should be coming in on your screens. And let me just go into presenter mode. Alrighty. Is that good for everyone? Yeah? Okay, excellent. Thanks so much for letting me know. Now, hello everyone. My name is Stella, and we're meeting today on March 25th. And I really hope that spring's going to start at some soon this year because it's been a super long winter. And before we proceed, I would like to acknowledge that we're meeting on the land that we work and meet on this land of the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by the Treaty 13 with its Mississaugas of the Credit. Now, in terms of the presentation outline, we're going to begin by me talking a little bit about myself, and then we'll proceed to discuss the social determinants of health and how they relate to health equity and the cancer care continuum. And then we'll go into some definitions around what is trauma and what is violence, and how do trauma and violence connect to our health outcomes within the cancer care continuum. And we'll finish today's presentation by discussing what is trauma and violence informed care and what are the principles that govern this perspective. Now, a little bit about myself. In terms of my academic background, I have a BA in sociology and a master's and a PhD in health policy and equity. In terms of my research interests, most of the work that I do revolves around social determinants of health and health determination, trauma and violence informed care, and health equity and social justice. I am also strongly guided by the political economy of health inequalities lens and how that affects public policy. In terms of my work, as Christopher mentioned, I work in Women's College Hospital, where I'm currently completing my postdoctoral fellowship within the Advancing Cancer Care Equity Lab. Now, we had to rename the lab because the acronym stood for ICE, and we thought that was not a good idea. So we had to change it to Advancing Cancer Care Equity recently. And majority of my work revolves around developing educational interventions for primary care providers on how to deliver trauma and violence informed care during cancer screening encounters. And not just the screening encounters, but when it comes to treatment and post-treatment and et cetera. And I will talk a little bit about that later, but the module that I'm working on is called Creating Safe Connections, and we can see the logo for it right on the bottom here. Alrighty, so let's dive into some of the details about social determinants of health. Now, social determinants of health are complicated, and we have been talking about them within the academia for about 3 decades now. And if you would like to read about the Canadian facts on social determinants of health, I would strongly urge you to access a free resource that was developed by a professor from York University called Dennis Rayfield, along with his co-authors. But social determinants fall within a very broad range of 4 buckets: economic factors, social factors, environmental, and structural. Economic factors examine things like income, employment, and food security. Social determinants focus on things like ethnicity, gender, disability, and immigration status. Environmental factors look into things like housing or geography, understanding where people live and how that affects their health. And structural factors will focus on policy and, for example, like social safety net. How much of these determinants are given to the majority of the people so that they can live out and have access to good health? Now, these factors, the social determinants of health, shape who develops cancer, who has access to care, and who survives. And we'll draw these bridges as we go along, but I wanted to introduce you to the social determinants of health so that we have this anchor as we move on. And social determinants of health are really related to the concept of health equity. And before we talk about health equity, I want to talk about what are health inequities. Health inequities are differences in health that are unnecessary, avoidable, unfair, and unjust, meaning that they're systemic and they're reproduced within our system and produced within both our political and economic systems and deprive some individuals within our society from having access to the resources that they need in order to have a healthy life. Now, when we also talk about health equity and social determinants of health, it's also important to talk about priority groups within each within these concepts. And the priority there are groups that are disproportionately affected by cancer in Canada. And these groups include individuals who are underserved based on their ethnicity or race, class, gender, ability, or other social identities. People who are living in rural and remote areas are also disproportionately affected by how they experience cancer. And communities, indigenous communities such as First Nations, Inuit, and Métis peoples also tend to have disproportionately higher rates of cancer or in access to treatment and screening of cancer. So these priority groups require specific actions to reduce the burden of disease. And this is why we talk about equity, because health equity does not just focus on what is avoidable, unjust, or um, unfair. It also focuses on what do each one of these priority groups needs in order to have access to screening, have access to treatment, and then have potentially longer survival or survive the disease. So each one of these groups will need a different approach because a one size fits all approach just does not work. And it's really important for us to note that a person can belong to more than one group at once. So for example, a Black woman living in rural area. And this is called what we in academia refer to as intersectionality, meaning that each one of us has multiple identities which intersect and often can have a compounding effect in disadvantage and underservice. Alrighty, so now let's move on and talk about trauma. What is trauma? And I always love to begin with definitions because they help us understand and situate the concept within kind of the larger area that we're talking about and the larger scope. Now, trauma is the experience of and response to a negative event or events that threaten a person's safety, life, or integrity and overwhelms their ability to cope. Traumatic stress can be acute, where it results from a single event, or chronic and complex, where it results from repeated experiences. In Canada, and this is a staggering statistic, approximately 67% of adults have experienced one or more traumatic event that would meet the threshold of post-traumatic stress, meaning that majority of us have some sort of experience of trauma or are currently living with trauma. And there are many different types of trauma. The three buckets that we have here are kind of very general, but let's discuss them. The first one is interpersonal trauma, and that can be a result of child abuse or neglect, abandonment, sexual assault, intimate partner violence, where majority of trauma and violence informed care kind of emerged from. There's also children's experiences of interpersonal, intimate partner violence, sudden death of a loved one, torture or confinement, abuse of older adults. Situational trauma includes things like war or genocide, being a victim of a crime, having an unexpected job loss, or being a refugee. Extreme poverty will also be coded under situational trauma, homelessness, natural disasters, and accidents. And collective trauma can be experienced in the forms of colonialism, residential schools, or even what we all went through during COVID-19. Now, the really important thing for us to conceptualize about trauma is that it is interrelated. And often we see this kind of a flow of interpersonal, collective, and situational trauma revolving in a fairly vicious cycle. And these kind of experiences of trauma might increase other types of trauma, leading to more complex and chronic forms. Now, responses to trauma are different for each individual who goes through it. And trauma responses can include shock, terror, shame, or powerlessness. And these sometimes are referred to as flight, fight, freeze, or fawn. What trauma looks like will differ between and among people and groups, and someone may not react the same way from one time to the next. Trauma responses are influenced by physiological factors, environmental factors, family, community, and social factors. And what is really important for us to note is that trauma increases the risk of chronic disease. Um, it it increases the risk of mental health problems and has leads to potentially harmful health behaviors, especially substance use. Now, being trauma informed means that we recognize that trauma affects many things about the individual. And it affects how people talk about their health. It affects how people sleep or whether or not they experience sleep problems, chronic pain, migraines, heart palpitations. Trauma can present itself in breathing difficulties, pelvic pain, anxiety, or depression. Trauma affects how people think as well, whether they're feeling disassociated, they have difficulty controlling their thoughts, avoiding certain people or situations, feeling overwhelmed or hypervigilant. Trauma also affects how people feel, not just think, which are connected, right? And it can present itself as irritability or being angry or numb, ashamed or guilty. Some people present trauma as feeling without purpose or hope, and for others, it will include self-hate. Now, trauma also affects how people behave. So, some people will behave in riskier ways where they will use substances to help cope with the stress and traumas that they're feeling. And one substance that I personally focus in my research is on smoking. Now let's move on to violence. Violence refers to any action, behavior, or system that causes harm, threatens harm, or creates conditions where individuals feel unsafe, powerless, or at risk. Examples of trauma fall within similar buckets as of violence, sorry, fall within similar buckets as trauma and include interpersonal, structural, systemic, and collective, environmental and community, and self-directed violence. Interpersonal violence includes examples like physical, sexual, emotional, neglect, or intimidation. Structural, systemic, and collective violence can be felt through our systems of racism, colonialism, sexism, discrimination, or within our public policies. Environmental and community violence can be experienced as lack of public spaces or increased community crime, and self-directed violence refers to self-harm. Now, violence is both a cause of trauma and often a response to trauma. So people often navigate multiple layers of violence simultaneously. And I want to spend a little bit of time talking about the impact of structural violence, because it's one of those things that's kind of hidden and we don't necessarily think about it, or we might not experience it in the same way as direct forms of trauma and violence. But there are structural systems which create a lot of trauma within people, and structural issues that impact well-being include things like racism, stigma and discrimination, collective and historic violence, and persistent poverty. Now, these are all equity factors because they are avoidable, they are unjust, and they are unfair. They're factors that are created by our systems and reproduced by both our political, economic, and policy systems. And these factors pose barriers in accessing cancer care screening and treatment for people who often find themselves navigating, or who exist within the axis of various identities, which make them more susceptible to experiencing these types of structural and systemic violence. Now, let's talk about trauma and violence informed care. Now that we have all the definitions of what trauma is, what violence is, how it relates to social determinants of health and health equity, there is a way forward where we can move on in a way that is going to reduce the amount of harm that is being done, not only on the individual level, but on the systemic level. And that's where TVIC, trauma and violence informed care, comes in. Now, TVIC is a universal approach that shifts the focus from what's wrong with you in the person's head to what's happened and what is still happening in the person's life. TVIC promotes empathy and it reduces judgment by reminding that behaviors often come from coping with trauma and its lasting effects. Importantly, TVIC brings attention to broader social conditions, including policies that are harmful and inequitable, such as structural violence, discrimination, and harmful practices embedded in the ways that our systems and people know and do things, such as systemic and institutional violence or implicit bias. TVIC brings attention to ongoing and historical violence, including collective violence, as well as interpersonal violence as complex and often chronic forms of trauma that affect attachment and trust. And importantly, TVIC brings attentions to the safety and well-being of peers, providers, teams, and organizations. TVIC is also about recognizing our own assumptions. So we may unintentionally assume that patients understand the healthcare system and that, let's say, everyone may have access to transportation or that everyone should feel safe in a medical environment and trust doctors. So it asks us to question these assumptions, which leads us to implicit bias. And implicit bias are those assumptions that we carry, the attitudes or stereotypes that affect our understanding, actions, and decision in an unconscious manner. For example, Researchers have found that healthcare providers often have implicit bias towards people living with mental illness, labeling them as unfixable or difficult. They avoid, healthcare providers will unintentionally avoid individuals living with mental illness because they do not feel like they can offer them any help. Now, from this point of view of a person living with cancer who may present it through impatience, avoidance, or other behaviors that are resulting from implicit bias, this can be experienced as stigma and discrimination. So, how can we raise awareness of implicit bias? Now, being aware of our implicit biases allows for better care by ensuring a more inclusive and respectful approach where people are not diminished or excluded based on pre-existing beliefs or stereotypes that we may carry. When you understand trauma, violence, and its impact on people's lives and behaviors, you stop asking, what's wrong with this person? And you start asking, what's happened or is still happening to this person? And importantly, how can I help? Now, why does trauma-informed lens and trauma and violence-informed lens matters in cancer care? It's because diagnosis itself can be, and it most often is, a traumatic experience. Medical procedures may be triggering, um, whether it's current forms of trauma or past forms of trauma, and healthcare mistrust may come from past experiences. Just a reminder, trauma affects communication. It can affect appointment attendance and treatment decisions. And that's where peer support is very important because it can become a safe relational place for people who are living with trauma and violence in order to access treatment, access screening, and have a better survival rate. Now, we present four principles of TVIC. There are others, but we focus on these main four in our lab, and they focus on understanding trauma and violence, creating emotionally, physically, and safe environments, fostering opportunities for choice, collaboration, and connection, and using a strength-based and capacity-building approach to support patients. So we're going to break down each one of these now. Now, the first principle of TVIC is understanding trauma, violence, and its impact on people's lives and behaviors. For cancer coaches, it can be viewing challenging behaviors and interactions through a trauma lens, being mindful of potential histories and side effect or effects, and handling disclosures appropriately. This looks like believing the experience, affirming and validating people's experiences, recognizing strength, and expressing concern for safety and well being. So instead of asking, why didn't you attend the appointment? You can try asking, sometimes a lot can get in the way of appointments. What made it difficult this time? The second principle of TVIC is centered around creating emotionally, culturally, and physically safe environments for everyone, for the patients, for the healthcare providers, and for the coaches, because TVIC focuses not only on the patients, but also on everyone who is involved in the circle of care. So, for cancer coaches, it includes being aware of impacts of power differences and boundary violations. It includes being non judgmental in your approach so that people feel accepted and deserving of your help. It includes clear information and predictable expectations about programming. And this is something that, just pause here for 1 second, that this predictable expectations keeps on coming up whenever I talk to primary care providers. It's something that primary care providers often forget, is stating what is going to happen next so that people are aware of their journey and what's going to happen. And for cancer coaches, principle two also includes considering how safety in relationships can impact service seeking and use. So, for example, instead of asking, let's talk about your plan, try asking, we can talk about whatever feels most important to you today, whether it's what your treatment is or just how you're feeling. So it's creating that space for safety, for just engaging with the person instead of having a plan of A, B, C, D. Alrighty, so let's move on to the third principle. And the third principle centers around fostering opportunities for choice, collaboration, and connection. And it's similar to the other principles that we discussed. And I would say that all TVIC principles, they inform one another and they should be viewed as kind of a holistic approach. So for cancer coaches, this can involve being not using judgmental responses, providing realistic options and choices for next step, considering choices collaboratively instead of telling individuals, because sometimes you may feel like an expert and you kind of feel like you know what's best, right? But it's building these opportunities for collaboration, active listening, and most importantly, privileging the person's voice. So instead of, here's what I think you should do next, you can try what feels like the right next step for you. That's when you're creating that opportunity for collaboration and connection and building of choice, which relates to the last principle of TWIG, which focuses on using strength based and capacity building approaches to support patients. So, for cancer coaches, that looks like listening for, validating, and helping identify the person's strengths, acknowledging the effects of historical and structural conditions, and teaching skills for recognizing triggers or understanding how to calm yourself and center. So, for example, instead of saying things like, you should try stay on top of things, you can try saying, it sounds really overwhelming right now. The fact that you're still reaching out shows a lot of strength. What has helped you get through tough moments before? And that's when you intentionally start to identify the person's strengths and lead, hopefully, work with them in collaboration to not only identify the strengths, but to begin to use them throughout their journey. So now, what does inclusivity look like in peer support? And I just have a few examples here, okay? So instead of giving advice quickly, which is something that we often try to do with the best of intentions, you may want to try asking open-ended questions. And instead of assuming that somebody has barriers, ask them about their priorities. Instead of focusing only on medical information, which is important, but it's not the only thing that really matters. You acknowledge emotions and how people are feeling in that moment. Instead of correcting behavior, try to explore underlying stress. And I have a few examples here of TVIC language. So you can ask, what has been the hardest part of this journey so far? Or is there anything making it difficult to access care right now? Or what supports would feel most helpful today? Now, for a bit of an interactive activity, and we have about 15 minutes, I would like to ask the audience to look or examine this case of Maria with me. Maria is a 52-year-old immigrant woman who was recently diagnosed with colorectal cancer. Because of this diagnosis and the multiple appointments that Maria has been having to attend, she has lost her job after the diagnosis. Maria is now hesitant to trust the healthcare providers because of past experiences from her home country, and she often cancels appointments with care providers. And I want to ask you, what might be happening beneath the surface and how you would address the issues? So I'm not, oh, yeah, I do see the annotate button here. So for people in the audience, if you would like to use the annotate button, go ahead. I have a little screenshot here of how annotate works. You may also want to drop your thoughts into chat. I think that's possible. And if you can, please unmute yourself so that we can brainstorm this together. So please take a few minutes and let me go back to the case itself for 1 second so that we can remind ourselves about Maria. So again, Maria is a 52-year-old woman. Now, Maria is 52, so she might be either finishing menopause or going through menopause. She's an immigrant who has been recently diagnosed with colorectal cancer, lost her job, does not trust the healthcare providers, and often skips treatment appointments or care appointments. So again, please drop your thoughts into the chat or use the annotate button to tell us what you think.
So Stella, just to clarify, we have silent viewers, so there's a lot of viewers that are watching in into the session, but we will also have a question period for coaches after in private. So maybe it's
Okay,
a good idea to formulate these ideas and we can bring them into that session.
that's perfect, Christopher. Thank you so much for noting that. Okay, everyone. So I hope you take a few minutes to think about this, and we can discuss this case later or any other questions that you have during the question period. And let me see. So I guess we'll move on from now and we can discuss this case later. But I hope that the key takeaways that you will leave today's session with are that every patient's cancer journey exists within a broader life context. So we cannot just think of people within this one moment in time, but really try to understand the context and the whole life story that people carry with them. And whenever I think about trauma and violence informed care, I think about the invisible backpack. It's kind of the backpack that each one of us carries, but we don't show people what's in it and they can't even see it because on the surface we might present as happy, you know, carefree people who might be going through specific stresses, but nobody knows what's inside that invisible backpack. So next time you meet someone, try to think about what are they carrying in their invisible backpack. And inclusivity in cancer care means creating safety, choice, and respect in every encounter. And peer support and coaches play a very powerful role in reducing isolation and restoring trust in people going through their cancer journey. I also included here, and if I hope that people will have access to the slides and be able to click on the links here. But these are two trauma and violence informed care courses that were developed by the Equip Lab within the University of British Columbia, which is where our course lives right now. We are working with other partners to develop different versions of the course so that it applies not just to specifically to lung cancer, which our module does, but to other cancers as well. So I'd strongly urge you, people in the audience, to check out these courses. They take about 2 hours to complete, and they really provide important information on what trauma and violence care is and how to use it in your interactions with people. I also have a few additional resources that I included here on informed trauma and violence informed care kits, equity oriented healthcare in general, and trauma informed physical activity toolkits. So that's for people who actually need to engage in some sort of physical activity, but through a trauma and violence informed lens. And I have some references. So my presentation is done, and I would like to thank each and every one of you for listening. I look forward to the questions, and I'll pass it on to Christopher now.
Thank you so much, Stella. Thank you so much for being here with us and for educating us on this imperative healthcare discussion, not limited just to oncology. We appreciate your work greatly. Just a couple housekeeping items. We do have an amazing educational video that will be airing during the lunch break. It will be airing in the lobby, and it'll be on Second Look Cancer, a global colorectal cancer clinical trials finder with Dylan Eisenhower. So please do while you're lunch, if while you're having your lunch, if you don't, if you can, please sit in and have a listen. It will be incredible. Lastly, an additional reminder that our post-lunch sessions will have a different lobby link, so please do utilize that new link. And our coaches can now head backstage for our question period, and we will see everyone after our lunch break. So this is an extended break at 1:45 p.m. Eastern Standard Time. We will see everybody soon.